Welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Board of Directors. Today's meeting is officially called to order. Please note for the record, Elizabeth Lauros will be representing Deputy Mayor Ann Williams Isom.
I'm sorry, the deputy mayor is on her
I'm
side.
sorry. Well, Michelle Morse will be representing Dave Shoxi, and Karen St. Hilaire will be representing Gary Jenkins, all in a voting capacity. So next on the agenda is the adoption of the minutes for the board meeting held January 27th, 2022. Are there any questions, comments, or suggested changes? So can I hear a motion to accept these minutes?
Motion to accept.
So let me ask for your vote individually. Dr. Katz?
Yes.
Dr. Calamia? Dr. Calamia? Dr. Marthone?
Yes.
Thank you. Dr. Morse?
Yes.
Karen St. Hilaire?
Yes.
Thank you. Deputy Mayor Ann Williams Isom?
Yes.
Thank you. Barbara Lowe? Robert Nolan?
Yes.
Sally Hernandez Piñeiro?
Yes.
Tenioski Peña Mora?
Yes.
And Anita Kawatra? Okay, so the minutes have been approved. So next on the agenda is the adoption, during the executive session, the board received and approved oral and written governing body submissions from NYC H&H Lincoln and Kings County. The board received and approved semi-annual governing body reports. These are written submissions from NYC Health and Hospitals Queens. So I want to move on, and Dr. Marthone conducted meet and greets at Coney Island, McKinney, and Kings County. Dr. Marthone, do you have any feedback or anything you would like to share from your visits?
Thank you, Dr. Pagan.
Yes.
So yes, I begun at Coney Island Hospital with Ms. Lipyanskaya and Peter Ginsburg, where her stance on society brought me to a quote of RBG's, where she said, "We have the oldest constitution still in force in the world, and it starts out with 3 words, we the people." So where I saw the ED, CPAP, and med-surg units, they're beautifully coming together, and how she showed me how they were preventing from suffering from the floods if it happened again. So the ED has now been moved to the 2nd floor, and institutional equipment will be moved to higher floors. And an interesting fact that I learned was during the pandemic, the elderly in that outpatient service area, catchment area, actually quickly adjusted to technology and kept their outpatient appointments, and also did all their follow-up in persons, which was really interesting to hear. So after all, renaming this institution to South Brooklyn Health and having RBG's name associated with it, we the people want to make sure that there are robust healthcare services available for the times. I also went to McKinney, where the staff and resident engagement was extreme, and all staff are leaders, and they're fostered by Mr. Weinstein. The cultural competency really shows up at every turn. However, the most touching moment was when I met a resident that was turning 104 in a few days. She was dressed to the nines, extremely well cared for, and despite needing help to accomplish her ADLs, had not lost her sense of independence in late adulthood. She outspoke us, and she represented everything and every reason we must continue to do the people's work on this board and have leaders that do the same in our institutions. And at Kings County Hospital, Mr. McLeod and the staff, I was very impressed. And the staff of the NICU, the ED, they were great. I saw the wonderful work they're doing there. We spoke on their incarcerated outreach program, Project Echo, which I was very impressed with. And did you know that they have one of the only Ronald McDonald House in the H&H system? I also learned that Major Walter Reed, yes, the yellow fever major, and he has a plaque on the wall there. And currently the same Walter Reed that has the Joint Arms Services Hospital Um, uh, he did a stint at Bellevue Medical College where he got a second medical degree in New York City, and then it was about 1870, and then he was at Kings County Hospital interning. So history means something, and it is often very enticing to the scientific mind. Having personally shared learning and growth in the same halls as Purkinje and been taught by the same co-inventors of ERCP, I can understand the law of history and what it can serve in recruitment and service, and enhancement of purpose for those looking to serve the underserved, and make for great retention if we continue to help to lead in quality and safe care, but look to see how we can also lead in meeting enhanced gold standards and creating cutting edge opportunities for care where we can. And I think this would be a great recruitment tool when we are out there looking for young physicians and minds. Thank you. And that was my experience with the 3 facilities so far.
Thank you so much for all your observations and the facilities at Coney Island. You know, I'm looking forward to seeing everything completed, and I'm glad that you had a good experience at the 3 of them. And yes, Kings County, every time that I've been there, I always learn something new when I'm there. So we got to figure out all these things that you mentioned on quality, on how to attract physicians that are really well aligned with our mission. So thank you for your feedback, Dr. Martone. So let me move the president's report towards the end, and we're going to move then to Vendex approval. Since we began the process of approving contracts prior to Vendex approvals, there are 15 items on today's agenda requiring Vendex approval, of which 12 have the approval. There's 7 items from previous board meetings pending Vendex approval. Since we last met, no approvals were received. We will continue to notify the board as outstanding approvals are received. So let's move out now to the resolutions, and we have 2 of them. So item number 2, so Ms. Hernandez Piñero, do you want to read the resolution?
Certainly. Authorizing the New York City Health and Hospitals Corporation, the system, acting in its capacity as the sole member of Metroplus Health Plan, Inc., Metroplus, hereby supports Metroplus establishing an internal audit to be known as Metroplus Health 1X or 1X to offer administrative and patient support services, including administrative services for and on behalf of self-insured health plans.
Thank you.
Good afternoon.
Dr. Schwartz
Hi.
is going to make the presentation.
Thank you. Good afternoon, Talia Schwartz, CEO of Metroplus Health Plan. So I'll provide the board with some background. Metroplus has been exploring launching a line of business through a separate division operating under the name 1X. Just so the board is aware, many managed care plans, called MCOs briefly, offer administrative and management services to fully insured plans and also to self-insured health plans, thus diversifying their revenue streams. The proposed 1X division would perform management functions to self-insured plans consisting of providing the network, performing claims management and processing, utilization review, and in some instances, if so desired, also case management for medical and behavioral health services.
Talia,
While
could
most-
you, maybe it's obvious, but could you say what a self-insured health plan is?
Sure. So it's actually it's coming in the upcoming
Oh,
bullet
okay.
points.
All right.
So while most MCOs bear risk for their members' claims and provide administrative and management functions, self-insured entities often lack the infrastructure to perform these functions. The contracted self-insured entities will bear the risk of employee healthcare utilization by financing payments to providers. 1X will administer the self-insured product and will bear no insurance risk. So essentially the difference between a fully insured and self-insured is a fully insured entity, just what Metroplus is, bears the risk. If the cost of medical services is higher than the premium we receive, we have a deficit. If the cost of the medical services we provide is lower than the premium we receive, we have a surplus. So it depends. We bear the risk in relation to the medical expenses. Self-insured entity will bear that risk and will be paying for the utilization and medical services of its employees. And the MSO will do all of the processing, all of the administrative work, but will not bear the risk. So if the medical expenses are lower in a given year, the employer benefits from it. If the medical expenses are higher in a given year, the employer again bears the risk. So employers can realize savings based on their employees' actual claims experience, rather than paying a predetermined monthly premium to an insurance carrier. So in the fully insured arrangement, the employer has a contract with an MCO and they pay a predetermined premium, regardless of what the utilization looks like. And in that case, the MCO takes the risk. In this case, the employer can fluctuate based on the actual utilization and either benefit or not benefit, depending on what the utilization looks like for their employees. A little more background. There are over 550 employers who have self-insured plans in New York, and Metroplus identified dozens of groups with historically underserved members who would benefit from our plan as the rising cost of health coverage increasingly challenge employers. So specifically, employers who are non-for-profit employers have been struggling in the last several years with increasing premiums that they are paying to MCOs. And so what we are seeing that more and more employers are actually switching to the self-insured model. The MSO can offer smaller, as I said, non-for-profit employers a more affordable option to continue to offer quality coverage. Metroplus intends to begin offering additional lines of MSO business through a new division called Metroplus Health 1X. This will be a cost-efficient way to enter new markets and add another revenue stream for Metroplus. And this division was approved by the Metroplus Health Plan Board on February 8th, 2022. Approximately 67%, sorry, I moved to the next slide.
Next slide.
Thank you. Approximately 67% of US employees with employer-sponsored health insurance are already in the self-insured plans. New York City realized over 15% growth in self-insured employers over the past 4 years. So clearly it's a growing market. Right now, Aetna, United, and Empire are the most dominant administrators of the self-insured plans in our market. Next slide. In terms of the value proposition, so 1X will offer quality, competitive, affordable, self-insured plan options, utilizing both broad and narrow network. This is a model we currently have in place for a different product. The narrow network plan will use only Health and Hospitals network, and the broad network will use Metroplus's full network of providers, and the employer can choose one or the other or both. And obviously, the MSO will build based on Metroplus's expertise in both administering the network, claims processing, including behavioral health claims at this point, case management, including behavioral health case management at this point, as well as addressing social determinants of health, pharmacy, and other needs. Although we're not always thinking about the employer market as needing support for social determinants, I think COVID demonstrated very clearly that there's a need in the employer market for this kind of support. Next slide. In terms of the benefit design, Plan options will consist of 3 different plans with slightly different benefit packages, reflecting low, medium, and high-cost sharing options, very similar to the QHP product with the different metal levels. The industry standard for administrative costs range between $30 to $50 per employee per month. And that includes just the basic services, which is the network claims processing, utilization management, COBRA, and call center. Many employers are interested in administering additional programs to help with cost savings. And those additional programs obviously have additional costs associated with them to the employers and additional potential revenue for the plan. Next slide. This is just kind of a quick demonstration of what the organization will look like. So it will be essentially another arm under our current board and under my oversight. The structure that you're seeing here is just kind of a basic structure that will fill all of the functions that are needed to run the administrative arm for self-insured employers. We anticipate, as we are building this unit, that there is going to be minimal allocation of existing employees to help us set this up. So the investment upfront is extremely minimal and relies on the expertise we already mostly have in the plan. Once we have identified clients and we have lives under this unit, there will be an additional investment to complete the build out of the MSO. In terms of the timeline, since the investment is not significant and it's mostly focused on legal compliance and IT areas, we believe that we can get ready to administer those services by July of 2022. And that completes my quick overview of the request.
Thank you so much. Let me go through the list here of board members in case, to see if they have any questions. Dr. Katz?
No.
Thank you. Dr. Calamia?
Yeah, just quickly, with regard to the way you're describing your business plan, it sounds as if we're basically relocating, or I shouldn't say that, just reallocating time from current with the system in preparation for this. And I guess I'm trying to get my hands a little bit better around what kind of investment are we talking about? Is there sort of a business plan? Do we have a sense of what kind of business we could expect, what kind of income we can get, and at what point that will come to fruition to actually, be able to separate out this component into a working part of the plan, as opposed to being kind of just having people do dual jobs within the plan.
Yeah. So the upfront investment is mostly around having policies and procedures from the compliance area. Because this is a different structure, we have not administered COBRA services, and so we need to develop that function. That's one part. The other part is around IT, because this is a completely separate unit from the HMO. It's critical that we have a completely separate flow of data. So there's no intermingling between the MSO data and the data that we have, especially for the government-sponsored membership. In terms of finances, again, full separation between the government-sponsored business and this business. So in terms of investment, this is really most of the investment. And then the last piece we need to get is an adjuster license to be able to do for an entity that is not us. So our estimate that to do all of this preparation in the next several months will take an approximate investment of $300,000. So that's what it will take, and minimal investment of time from existing employees. In terms of looking forward and when do we think we will break even and how many lives, we expect to have approximately 12,000 lives to be able to break even, right? So once we have an actual contract signed, it will not be any longer just Metroplus employees. We will actually hire dedicated employees. The number of employees will depend obviously on the size of the contract, but essentially, for us to become profitable, 12,000 covered lives, we expect that we will get there approximately in the second or third year of operation, with a projected conservative revenue of $7 million.
So there'd have to be a considerable marketing component to this as well. Is that something we're looking upfront to start, I guess, initiating some of these potential clients? Or how is that all being sort of sorted into this? Is that all part of the $300,000 budget?
Yeah, so very good question. So number one, we were approached already with some interest. We didn't have the product to offer, but we were approached with some interest from several parties. In terms of marketing, this can be part of what our marketing leadership is currently doing. So that will not require any specific additional investment, at least not out of the gate.
Thank you.
Thank you. So Dr. Marthon, Patricia, any questions?
No questions.
Okay, thank you. Dr. Morse?
Thanks so much for the presentation. I was just curious to know if there are things that you expect to learn from the 1X system that you think will be applicable for other Metroplus clients, and if you could share a little bit about how you anticipate learning from that, if that's possible with the administrative structure.
Yeah, our current commercial book of business is pretty limited. We certainly have one, and it's very successful, but it's limited. So having additional commercial clients, kind of meeting their expectations, their SLAs, will certainly help us on the government-sponsored side. We also know that this is not specifically to your question, but I just want to mention that people's income change and their situation change all the time. We currently see members moving between different lines of business. So we see this opportunity potentially also as a feeder into our government-sponsored products. Right? If somebody loses their employment, they're able to choose another product that we're offering for somebody who is unemployed. But specifically to your question, working again with a commercial type of business certainly opens opportunities. I see this more around the social determinants and case management and those areas, and less so in kind of the more core functions that I think we were able to figure out, and we operate at an industry level when we're talking about network and claims processing and medical necessity reviews.
Thank you.
Thank you. Karen Saint-Hilaire, any questions? Karen?
No, I don't have any questions. Sorry.
Thank you. Deputy Mayor Ann Williams, Ism?
No questions.
Thank you. Barbara Lowe?
Oh, yes. Hi there. This sounds pretty interesting to me. I'm a former employee of the city hospital system and a senior citizen. And I could tell you that we need better products, better opportunities. For instance, eye drops for glaucoma for me went up 500% in one swoop. And I would like to see that there is more thought given to plans that suddenly go the other way or prevent them from going the other way. So please tell me what, if anything, in your future vision would you have for plans for retirees from the system? Right now, they can opt in under the OLR, the labor mechanism. But very little information was provided for retirees when the options were formed, and they were exposed, like myself, to a huge increase in medications, for instance. So I don't know if I'm feeding into your future vision for this or not, but I think it's a consideration probably now. I think a lot of people would have questions. I'm able to put my questions forth as a nurse myself and understand the problems, inherent problems. But I'm sure there are others who don't even know what's hitting them until they go and get a prescription filled or some other.
So,
Mhm.
yeah, I mean, obviously, we're aware of the new proposal for city retirees. We are at present, we're not part of this solution.
Okay.
So the solution that we're talking about does not apply for Medicare. So the solution will be for current employees that are covered under employers. But I think you bring a point that doesn't apply necessarily to retirees, but you bring a point which kind of propelled us to offer this product.
Mhm.
And the point is, many of the employers, especially the non-for-profit, are struggling with affording health coverage for their employees. And you're right, the cost continues to increase. And sometimes we're talking about double digit and high double digit.
Oh
I
yes.
know a specific example where a premium went 27% from one year to the next.
Mhm.
And so the employers, unfortunately, are kind of at the mercy of the cost. What this solution offers is for the employers to tailor a solution for their employees.
Mhm.
So, which means that they can, depending on their employee demographics and needs, they can really hone in on certain services and discount certain services, and maybe forego some services that do not apply to their demographics. And so it can be customizable, and because of that, it can be more affordable. So that these type of employees who are already kind of the underserved employees can actually afford their medication and afford their health care.
Well, I thank you for that. I'll keep up with my advocacy for better options.
Thank you. Thank you, Barbara.
Thank you.
Robert Nolan?
Yes, I'd like to express my appreciation to Metroplus for not just resting on its laurels with the services that you provide right now, but
Mhm.
being innovative and expansive and looking at other markets where you believe that you can offer services that are being presented now, but you could offer them better. So I congratulate you for that reason, because that's really what everybody is about here. Everybody can just serve their market and sit there, but that will not satisfy this board, because the board wants to see everyone do everything they can to expand that market. So congratulate you and the members of the Metro Plus board for moving in this direction. Thank you.
Thank you.
Thank you. Sally Hernandez Pinheiro?
Yes, Dr. Schwartz, I'm a self-insured employer, and I'm sitting here and I'm going to consider whether I should just continue doing business as usual, whether I should go to a provider, a private provider, and pay whatever premiums the system is now charging, or whether I'd look at Metro Plus. And I guess in evaluating Metro Plus, since they continue to bear the risk or the cost of the medical claims of their own patients, I guess the value added for them is right now, would they have their own administrative structure to deal with the claims they currently pay?
No, the MCO that they contract with is providing the administrative services.
I see. So the value added for them is that we could offer more competitive administrative services and a more tailored, a more customized plan.
Right, right. So the value, and that's a really good question, Sally. The value add is that we are able to offer them what I call a cost-effective type of network, right? They have an option of the Health and Hospitals network, or they have the option of the Metroplus entire network. Either way, it's a cost-effective way for them to offer quality coverage for their employees. So that's one part. I think the other part is providing kind of the add-on services around case management, both for medical and behavioral health services, integrating them together and through effective case management, lowering the avoidable costs. So that's the other part. And then the third part, as I mentioned, we don't think about the employee market as a market that needs support with social determinants of health, but that's a misnomer because these type of underserved populations do need help with social determinants, and this is something that Metroplus does well.
Thank you.
Okay, thank you. Fenioski Peñamora?
Thank you, Jose, and thank you. I want to echo what has been said. It's really good that MetroPlus is looking at how to increase their services. I just have a question following on Dr. Calamia's question. You mentioned that at this point is minimal investment, and you mentioned also like it would be around 300,000 to get you to the point to get the basic resources that you need. But at what point do you need to bring more people? Like the current group of employees that you have in MetroPlus, how big of a plan can they handle? At what point, what number of clients or number of insured, self-insured people will you have to go and grow and create an infrastructure, and how much will that infrastructure cost?
Yeah. So as soon as we have a signed contract, we will add additional FTEs. So the plan is to rely on our current employees as we're building the infrastructure. Once we actually go live, post a signed contract, we're talking about hiring additional people and not relying on existing employees outside of the executive team that oversees the whole operation. We have estimates of how many FTEs we will need to add based on how many lives we will cover. So there are ratios that we're currently using for call center, for claims processing, for utilization management. All of those are volume-based. There are other functions that are not volume-based that are just required, such as claims and somebody who oversees the whole operation. So it varies. The number of employees varies. Some of it, as I said, is just a constant overhead, and some of it completely depends on the volume of contracted lives. For us to make this work, we would need to contract with employees who are around kind of the 2,000 mark or larger. Just because what I mentioned, each employer can require customization, and that obviously that customization, building this up and administering in the way that the employer wants, requires some additional overhead. So out of the gate, we'll be targeting kind of those slightly larger employers of, as I said, 2,000 or higher.
So, but how you calculate in that case, what will be your initial investment? Because again, when you say it's minimal investment and it's only 300,000, but then, if you get the first client and you have to build up all these resources, what will be your break-even point? How many lives do you have to have under insurance to make it to the first breakout point? I know that as you grow, you will add more resources, but there is some sunken cost that you need to invest to provide the services if you wanted to continue to attract clients. Because if people call and don't get an answer, they are not going to be pleased, so you're not going to get clients. So have you done the analysis of what is your break-even point in terms of number of lives under management?
Yes, so it's approximately 12,000 lives.
12,000 lives. Okay. Okay.
Yeah.
And the funding for all this, and how much it will be until you reach to 12,000? It's like what, couple of millions? How much it will cost to create the infrastructure to support up to you get to the 12,000 lives?
Yeah. So we actually, it's not in this presentation, but we have the number of employees. We're talking about approximately various levels of employees, approximately a dozen employees that will support the first 12,000.
But how much is in money? Like how much it will cost you to get there, and where is that money coming from?
So the money is coming from our interest on investments. So the money obviously cannot come from any of the government-sponsored programs. That's that's a big no-no. That's why there's a full separation. But Metroplus is making money from investments. So that's where the initial investment, the minimal investment, and then the additional investment that we will require to staff up to the 12,000 until we break even. So all of the money is just coming from investment.
And
None
you
of this
know
is
how
from
much
premium.
it will be that first chunk? Like to
Up
step
to,
up to,
yeah, so it is several $1 million. I don't have the exact number.
and your revenue from your investment will cover that completely and still leave
Easily.
you enough room to continue to provide the services at the level of quality that we all expect in your other areas.
100%. We're well positioned to be able to do that very comfortably.
Okay, it will have been nice to have that information connected with this proposal, because right now I feel like we may be approving something without full information. That's just my thought.
Yeah, that's a great point, Feniowski. I think part of it is that it's connected to the establishment of the resolution is about establishing the unit, because it's not fully operational. I know that there are many issues that need to be sorted out anyway through the process, but thank you for that key point. Any other? Do you have any other questions on it, or?
No, that
Or-
answers my
yeah.
question.
Yeah, thank you. I think I have Anita Kawatra. And I see Frida
No
Wan.
questions,
I don't
but
know.
thank you
Okay.
again. I think this is
Thank
a
you,
great,
Anita.
a great program.
And Anita Kawatra? I'm sorry, Frida Wan. Thank you, Anita.
No additional questions. I thought that the discussion with Feniowski was useful on understanding the financials, and I do think it's great that we're Metroplus is taking this on.
Yeah.
So
Thank
you.
And the comment that I wanted to make on this is that I think this is it's great to be thinking about all these different lines of business, and the thing to keep in mind, and it goes back actually to the work we do with strategic planning, which is like, as we attract members to a product like this is a great opportunity to live up to our commitment for equity and so on. So to the extent that this allows the population that we serve to have better choices, employers that do business in the neighborhoods that we serve and so on, to keep that in mind as you attract or decide which employers become sort of like part of this network, part of the process. So thank you. So let me
It's
yes,
Barbara. I was trying to get in to say one last thing, please.
yes, go ahead, please.
I just would like to recognize the phenomenal work that's been done with the leadership over the last couple of years and turn around this particular plan to be a real successful plan in terms of the growth of your base of patients or clients, etc. So thank you so much. And I have the confidence in you that you will get to the next plateau as you have proposed. All the best.
Thank you.
Okay, thank you. So let me call for a vote on this, Dr. Katz,
Yes.
Dr. Calamia,
Yes.
Dr. Marthone, Dr. Morse,
Yes.
Sorry. yes.
Karen. Thank you. Karen St. Hilaire,
Yes.
thank you. Deputy Mayor,
Yes.
thank you. Barbara Lowe,
Yes,
Robert Nolan,
Yes.
Sally Hernandez Piñero, Fenioski Peña Mora,
I abstain because I feel that I don't have all the information necessary to the commitment at this point, so I abstain.
thank you. Anita Kawatra,
Yes.
yes. I see Frida Wang,
I vote yes. I would also like to see the information as well, if that's, we could provide that, but I do vote yes.
okay, thank you. And Jose Pagan, yes. So, yes, so the resolution passes. Thank you. So,
I'm sorry, Jose.
go ahead.
Would it be possible,
Yes.
Benny, to vote conditioned on getting the information that you need? The incremental costs for growing the program. The source is clearly a source from within Metroplus. So, and the amount of interest earnings is far, far, far in excess of the amount that would be projected to be needed to ramp up. So that's my question.
That's why actually I voted abstain and no, because I feel that I don't have, I feel that I don't have the information,
Yeah.
and it will have been good
And
to have that part of the package. I feel that I don't have the information.
Yeah. So, Fenioski, and that is fine, and we will provide that information to you and to the board so that they have that information. So, okay, so thank you so much, and thank you, Sally, for the comments. So
Sure.
let me move on to the next one. Is I think it's you, Dr. Peña Mora.
Yeah,
The next one.
sorry. Yeah, let me go back.
Yeah.
Thank you, Mr. Chair. This is item number 3, authorizing New York City Health and Hospitals Corporation, the system, to execute agreements with each of the following: Momentum Resource Solutions, LLC, Tech Services Incorporated, TCOM or GCOM Software LLC, Spires US Incorporated, City Info Solutions Incorporated, Integrated Resources Incorporated, K-Force Incorporated, Stellar Services Incorporated, Spruce Technology Incorporated, the CGS Solutions Group, LLC, business as the HCI Group, PAK Systems Incorporated, 314A or 314E Corporation, Gevity Consulting US LLC, OST Incorporated, W3 LLC, doing business as Healthcare IT Leaders LLC, the vendors, for the provision of information technology supplemental staffing services as requested by the system. The agreements shall be for an initial term of 3 years with 2 one-year options to renew solely exercisable by the system and with a total amount over the combined 5-year term not to exceed 283 million. This was presented to the Information Technology Committee on February 7, 2022, and it was approved for consideration by the board. Thank you.
Thank you.
All right, I'll begin.
Go ahead. Yeah.
All right,
please.
thank you.
Kim-
Hi,
Kim
I'm
Mendez.
Kim Mendez. I am the Corporate Chief Information Officer, and I'm joined today by our AVP of Finance and EITS, Apoorva Carrier. So as we continue to recruit, for our current vacancies in information technology and meet the needs of our short and long-term projects in a timely and flexible way, we are presenting this request to enter into contract for supplemental staffing and information technology. From a current state, our current 17 requirement contracts for IT supplemental staffing will expire at the end of June 30th, 2022. And New York City Health and Hospital, EITS, conducted an RFP to identify vendors that will provide the competitive pricing as well as quality personnel with technical skill and expertise in care information system area. As an option, EITS did conduct a detailed analysis of our system managed service provider, looking at the workflows, the processes, the reporting capabilities to meet the needs of both of our internal and external reporting requirements. After due diligence and an internal review with our stakeholders, and for example, in HR and supply chain, EITS decided to move forward with an RFP. We can move to the next slide, please. Just looking at some of the benefits of the supplemental staffing contracts, these contracts allow New York City Health and Hospital to achieve flexibility to quickly align with changing technologies and respond to new business needs in a cost-effective way. I will pause to say that the contracts are not just for IT department formally, they are also used by data and analytics as well as finance. And they have never been more important to us than over the last 2 years as we were addressing the dynamic and changing needs as we responded to our COVID pandemic. Our vendors will provide as needed labor for a wide array of technology expertise. The payment will be based on the services performed pursuant to our work orders. The vendors will also be required to comply with H&H onboarding and offboarding, just to emphasize that this will align with all of our COVID vaccination and booster requirements. And in addition, there will be no requirement of a minimum payment if the vendor's contract services are not utilized. Next slide, please. I'd like to turn over to Apurva, who actually led our procurement process with our colleagues in supply chain.
Thank you, Kim. Thank you for this opportunity, everyone. So this slide really provides an overview, a high-level overview of the procurement timeline. The RFP was posted on City Record in September. 59 vendors attended the pre-proposal conference. We received 43 proposals. In December, the evaluation committee did do an initial scoring. This scoring was finalized in January, and we selected the 15 vendors for the final pool. Moving to the next slide. So this is the list of the 15 vendors that was previously read, so I won't go into the details. Moving on to the next slide. This provides a summary of the vendor pool. Every vendor that is selected has more than 5 years of experience providing healthcare services with an annual sales of at least $5 million. While each vendor does have their specialties and core competency, all of them are able to meet the specified staffing needs for EITS, along with providing an approved MWB utilization plan and are being certified themselves. All the pricing and rates that were proposed were measured against industry standards, as well as our current baseline rates to ensure competitiveness. All of our vendors demonstrated competency in IT project strategy as well as delivery. The evaluation committee also reviewed the vendor performance for incumbents on our current contracts, as well as reference checks were successfully conducted for all of them. Next slide. This is really the details of the RFP. So the minimum criteria that were outlined in the RFP were MWB utilization plan, prior experience in large healthcare IT businesses greater than 5 years, minimum annual revenue of $5 million, as well as their ability to fill specific roles through subcontracting with MWB vendors. The primary substantive criteria that were utilized to evaluate all our proposals were 30% given to experience, 30% cost, 20% organizational capability, and 20% for MWBE. I do want to point out that the standard rate for general RFPs is 10%. We did weigh MWBs at a higher score criteria. The evaluation committee was a mix, had representation from core EITS program areas, along with outside of EITS quality and safety, as well as HR. Next slide. So it's a little difficult to read, but this is the summary of our vendor commitment and vendor diversity pool. Of the 15, 5 of them are MWB certified, either New York State or New York City. 1 of them is pending certification, and 9 vendors have submitted MWB utilization plan committing to either 30% or higher of
spend through MWB subcontractors. The slide also provides a list of subcontractors that each of the vendors has proposed. Next slide. So EITS worked very closely with the vendor diversity team to develop this RFP and to structure the scope of work in a way that we can maximize MWB participation. One of the key things and changes we made, as I mentioned before, was increasing the MWB E-score to 20%, whereas 10% is the standard weight. In addition, in the RFP itself, we noted and provided language that will allow maximum flexibility for H&H EITS to have sole discretion on managing the process and to aid MWB participation. EITS will work closely with the vendor diversity team to ensure compliance with each of the vendors' MWBE goals. Our overarching goal is to ensure that at least an overall 30% MWB utilization among the pool of vendors. We will also work under the guidance of the diversity team to implement various management tools to monitor the contract spend, including quantitative scoring on solicitations, closed pool solicitations among MWBs for certain specific appropriate staffing titles, as well as discretionary awards. EITS and the vendor diversity team will report periodically to the board IT committee on the MWB performance of this pool of contracts. Next slide. So in closing, New York City Health and Hospital, EITS seeks approval to enter into three-year contracts with two one-year renewals. Thank you. Okay, it's okay. At the discretion of New York City Health and Hospital with each of the following vendors. With not to exceed amount of $283 million. The term will be from July 1st, 2022 through June 30th, 2027. Estimated cost through that not to exceed with the renewal term of $283 million. No minimum usage is required, and we do have a termination for convenience at the discretion of New York City Health and Hospital.
Thank you so much.
you.
I may run into a quorum issue, so if anybody has any questions on this, please go ahead and.
I do have a
Dr.
question.
Please.
In the particular case of the vendor that it is looking for the certification with New York City as MWBE, if they were not able to get that certification, is there a plan B in which they will meet the 30%? I know that we are all hoping that they will get certified, but is there a plan B?
I can speak to that. Hi, it's Keith. Apologies for not being there, suffering a cold. Yeah, sure. We will negotiate at least a 30% MWBE utilization plan with them. So Kim and Apoorva and my team, as well as the supply chain team, have good track records with these firms already, and we would expect that to be the case going forward.
And the contract, it does state that if they don't get certified, they will commit to the MWB. Because again, one thing is to talk about it, but if you don't have it in the contract, it is not enforceable.
Agreed, Fenny. So also I should just state, excuse me, we don't draft the contracts prior to the board's approval. So we will make sure that gets documented in the contract as well.
Thank you. That's all. Thank you. Thank you.
Okay, any other questions or comments? Okay, so let me then call for a vote on this. Dr. Katz?
Yes.
Dr. Calamia? Dr. Marthone?
Yes.
Thank you. Dr. Morse?
Yes.
Karen St. Hilaire?
Yes.
Thank you. Deputy Mayor Ann Williams?
Yes. Yes.
Thank you. Barbara Lowe?
Yes.
Robert Nolan?
Yes.
Hernandez Piñero?
Yes.
Penioski Peñamora?
Yes.
Anita Kawatra?
Yes.
Jose Pagan, yes. So the resolution passes. Thank you so much.
Thank you.
President's report, Dr. Katz.
Yes, thank you, everybody. We're very glad that we're finally seeing a decline in the number of COVID-19 cases and hospitalizations. The Omicron variant hit us very hard in December and January, especially because so many of our own employees were sick, and therefore not able to care for the many patients who needed hospitalization. But we got through it. We did a lot of level loading among our different facilities. We even helped one of the nonprofit hospitals by taking some of their patients. Test and Trace administered more than 10.5 million tests, which is just amazing. We're now doing a large number of home tests, which we've distributed through libraries and cultural institutions. We're working out new advice to people on exactly what to do when they become COVID positive, including how to isolate and quarantine, and in that process have delivered more than 2 million meals so that people do not have to go out. We were at the beautiful new COVID Gotham Center with Mayor Adams, talking about our commitment to caring for people who have long haul COVID, and the center looks beautiful and is in Bushwick, Brooklyn, where it'll care for a group of people who were hard hit by the pandemic. We benefited from the Department of Defense helping out at both Coney Island Hospital and NCB. We were very glad to be with the governor and have the support of the Biden administration so that we can care for all of our patients, and our physicians and nurses and other support staff can get a little bit of downtime. The New York State suspended the booster mandate for the time being, as they're looking at exactly how to balance the need to maintain a sufficient number of staff with the desire to have people fully vaccinated. We had a great session with the mayor and Dr. McMacken on our lifestyle medicine program, which is a sort of first in the nation, really rolling out a plant-based lifestyle program. We've had a ton of interest and support. Anna had arranged a really great session with ethnic media to get out our message to smaller markets, and we're very proud of the efforts. We were also able to celebrate 100,000 NYC Care member, and we had two of our patients speak at the session about how much it meant to them. For Black History Month, 6 of our leaders were acknowledged as part of Cranes, and we are so proud that there are so many phenomenal African American leaders who are part of Health and Hospitals. Board knows with your support, we've appointed Dr. Leung, Senior Vice President of Post-Acute Care, and Linda DeHart, Vice President of Finance. We're very thankful to the mayor for his investment in New York City mothers and young families by adding $3 million to the obstetric simulation. And we're very thankful the deputy mayor came and saw how we teach shoulder dystocia prevention at our simulation center. Simulation is key. You know, when I was a resident, everything was, see one, do one, teach one. And we know why that's wrong and not good. People need to have experience, and we want the experience to be in mannequins until people are good enough in order to be able to do that with people. Governor Hochul proposed a $216.3 billion budget for the state fiscal year, which had a number of positives for us. And in particular, she recently announced that there would be a mental health rate improvement, which would be of great help to us because New York City Health and Hospitals does the disproportionate share of mental health care for hospitalized patients in New York City. While we represent 20% of inpatient medicine volume, we represent about 55% of mental health inpatient volume. And that's because the rates for mental health don't cover the costs. And so the private hospitals have gotten out of the business of doing psychiatric care. And we have picked it up because we are mission-based. And so we recognize the need. But having an adequate amount of money to do that care will make a big difference. Under contracts, I'm just going to read this for the record, that because we had an emergency with the Omicron wave where we had to markedly increase our services in order to meet the need. The emergency declaration was effective through January 31st, 2022. While we have several contracts in place to respond to the city's needs, the scale of the Omicron wave created increased demand for services as well as additional services to support our response. There were 5 actions taken that I want to bring to the board's attention. 3 for staffing for our hospitals, nursing homes, testing centers, and the hotels we manage on behalf of the city. Those agreements were for $90 million. And we expect that this will be reimbursed through FEMA and city funds. The other 2 actions were to support enhanced community testing and community outreach and education. The additional community testing contract is $11 million, and the outreach education support increased to existing agreements is $6 million. We expect these expenses will also be reimbursed to us through FEMA and our OMB MOU. And I've listed the vendors: Comprehensive Health Services, Crucial Staffing, Doral Medical and Multi-Specialty Facility, and a variety of T2 canvassing contracts. Mr. Chair, that's my report. Thank you.
Thank you so much, Dr. Katz. Any questions for Dr. Katz from board members? Or comments? Go ahead, Dr. Morse.
Yeah,
I think
thank
you
you so
raised-
much. I just wanted to, number one, say how much I was impressed by how the entire system did with the Omicron wave, particularly how steep the increase in cases was. And thankfully, knock on wood, how steep that decline has been as well. But one of the trends that we've been looking at very closely at the health department is the fact that the hospitalization rate for Black New Yorkers is around 2 to 3 times higher than the rate for white New Yorkers and is higher than all racial and ethnic groups. There are obviously a lot of different potential reasons for that, but I'm just curious to know how you all are thinking about that, or if Dr. Katz, if your team is kind of doing a little retrospectogram to think about how that might be prevented for future waves, since we have to, of course, do all the planning we can right now for future waves.
Sure. Well, of course, because health and hospitals so much takes care of the Black and brown communities in New York City, we always see a disproportionate number of cases. So you really have the population denominators in a way we don't, right? We're used to, that these are the people who come to us, who trust us, who know we care about them. I would think that a lot of this would reflect both the historic inequities and the differentials that may exist around vaccination. And we're certainly doing our best to promote vaccination and boosters among our own patients. But I think it falls more as a general city question of how when people need services, it's a good thing that they come to us to get them, and it's a good thing that they come to get the services. The question is, how do we help them so that more often their baseline status is such that the vaccine does not, cause them to become sicker. I think a lot of the patients that I saw with Omicron were pushed over by underlying illness, by underlying asthma, underlying heart disease, underlying diabetes. And had they not had the underlying illness, I feel like they would have been okay. But that the combination of Omicron plus the underlying illness pushed them over the line. But we're happy to continue to work with you on dealing with these disparities.
Thanks for that, Dr. Katz. Yes, and
Uh,
we agree. We're looking at the booster and vaccination data. But I think part of what we're struggling with is the monoclonal antibody access and how proactive we can be in getting folks treatment with monoclonal antibodies. I know we have a lot of work to do in that realm. Thank you for that.
Yeah, I would just, on that, I'd agree. I've been surprised, and I wonder if you are too, how low the interest in the use of the oral agent by Pfizer is. I would have said, having done worked around the monoclonal with my own patients, that I kind of understood, okay, you're minimally symptomatic now. I'm telling you that there's a treatment, but you have to go to the hospital. You have to get an intravenous treatment. You're going to be watched for an hour for side effects. That sort of sounds scary. Instead, okay, I'm going to prescribe you this medicine. You're going to take it for 5 days. That kind of sounds like a Z-Pack, right? Which we've done for generations. I would have assumed demand would be high, and yet it has not been. People have not been interested, and there may be a disparity, but the overall thing is most people aren't interested, right? Most Caucasian people are not interested, right? So even if there's a disparity, there is a general surprise in my mind at how little interest there has been in the oral and monoclonal agents.
Yeah, totally agree. I think part of it is also that people are getting tested in a place where they may not be, talking to their provider at the same time. So they might get tested, either an antigen test at home or they're getting tested with you guys, but then they may not call their provider to say, "Hey, I tested positive, what can I do?" And so we think we're also, it may be that people don't know about the treatment or that they're not in a place where they're getting tested and can get advised about what antiviral they qualify for. So that's definitely an area we're interested in working on. And certainly there are regional ways that we could focus interventions and partner with you all around that. So definitely agree.
That would be great. We would like that.
Thank you. And Dr. Peña Mora, you have a question or a comment?
Yes, sorry, I was going to mute. Again, thank you. Dr. Katz, you know that one of your biggest admirer. If you have a fan club, I'm the president. So I just want to tell you that what you are doing and the whole thing is just incredible. I particularly really pleased on that investment for our patients that have long recovery and having a facility that really supports their need. I just have a couple of questions. The announcement that was made I believe at Jacobi, like maybe 3 weeks ago, about the delivery of the COVID medicine if anybody has COVID. And I don't know how is that progressing, how we're doing in that delivery. Are we meeting the expectations? Are the numbers there that we expected? That's one. And the other one is the in-home testing, because I have heard from some people how long it takes for them to get appointments for somebody to go to their home if they cannot go, particularly the elderly. So I don't know if you have any comments on those two issues.
Sure. Thanks, Fanny, and thank you for being the president of my fan club. I greatly appreciate that. On the first, we haven't had any difficulty meeting the demand for home medication, but that's unfortunate because most people are uninterested in the medication.
Okay.
So we've been able to meet. In fact, we were very concerned that just the volume of drug was going to be incredibly insufficient in New York City based on the number of cases. And it just hasn't been because most people have not wanted to take it. And I think it goes back to what Dr. Morse was saying. We have to create a expectation that this is what you do. The same way there's an expectation about, taking an antibiotic with a urinary tract infection. It's a relatively minor infection, but people know, I have a urinary tract infection. I'm going to need to take an antibiotic for 5 days. We don't have a similar general understanding or thought, I tested positive. I need to take this oral agent for 5 days. In fact, one of the most interesting things is that the demand for the monoclonal is actually higher. And we think part of that is because there's been more publicity about people going and getting the monoclonal. And so it's at least in people's minds that you should go and get the monoclonal, and that maybe that this was, something special. So on the home testing, two things. Yes, if someone calls our line today, there will be someone tomorrow doing the test, at worst 2 days, but most often it's tomorrow. And they can also, if they have a family member, they can go by the library and get a free COVID testing kit. And so we have seen a lot of people getting home test kits now, and having that be. So that makes it much easier. But yes, home testing 1 or 2 days.
Oh, that's good, because what I was hearing of some people is 7 days. So it's good to know that now we're talking about 1 or 2 days.
Yeah.
And before I give the floor, sorry, I do have to say that Dr. Morse also is competing, because I heard her in one of the Spanish announcements for the COVID, and I'm telling you, she's doing a good job on making that public announcement. So I may have to
She's
divide my
terrific.
time.
She's terrific. We all agree on that.
Yes. Sally has a comment or question. Go ahead. You're on mute.
I'm sorry. There are two reasons why the pills are not being, haven't taken the traction we thought they would. One is that at the announcement, it kind of was emphasized that it was especially for folks that had additional comorbidities. It sounded like a very narrow universe of people that would get priority. And the second reason is what you said, Mitch. It was a one-day news story. I haven't seen it mentioned anywhere else. I had occasion to think about using it, and it took me a little while to track down the system that we used to find out whether you were eligible even. So I think it would be useful to have more publicity around it, more of our own marketing in the appropriate channels.
Right. Well, I think that's what Dr. Morse was suggesting we do together, is figure out the strategy. And it's true that in the beginning, and it's obviously how you learn things, we were afraid that we would run out of it immediately.
Right.
And that the people who had the comorbidities wouldn't get it, and that we needed to, make sure that we had the supply for the people who would most benefit. But now
Right.
we're in a position where the supply is, we're not using the supply. And, Pfizer is obviously a multinational company, and this is a big potential moneymaker. I mean, at some point, they're going to make it super easy for everybody to get it at the pharmacy, because that's what national pharmaceutical companies do. And I'm not aware, it's not a large molecule. It's not difficult to manufacture. So at some point, I suspect it will be as easy to prescribe as a Z-Pak is now.
Right. Okay. Thank you.
Okay, thank you so much. So I'm gonna move on then. To committee and subsidiary reports. The committee reports were emailed to you and are in your folders for your review and submission into the record. Is there any old or new business to come before this board? Hearing none, then the board meeting is adjourned. Thank you so much.
Thank you,
Thank you.
everybody. Nice seeing you.
Good
Thank you,
weekend.
everybody.
Bye-bye.
Thank you, everyone.
Thanks.